Welcome to the Peak Performance Podcast, your guide to optimizing your life one health tip at a time. This podcast is designed to entertain and inform, not to provide medical or health advice. Always consult your doctor when it comes to your personal health or before you make any changes to your diet, exercise, or lifestyle.
Peak Performance Podcast, y'all. We're here. I'm Coach Kyle.
And I'm Dr. K. Thanks everybody for joining us as we dive into diabetes and glucose. We're going to talk about diabetes testing. What is diabetes? How is it defined? We're going to talk about natural ways to manage your diabetes versus medication management. And we're going to talk about, effects that diabetes can have on you. And one last hidden gem, which is called metabolic flexibility. Let's get into it.
Very nice. So Dr. K, is it diabetes or is it diabetes?
The only person saying diabetes is Cletus. Everyone else says diabetes.
Well, not only diabetes, but really we're going to start with the whole scale, and then we're going to dive all the way into basically just glucose control and start touching on metabolic health because it's applicable to everyone. It's not just those who have been diagnosed with disease. Is that correct?
Correct. There's far precursor steps before you actually hit what's classified as true diabetes.
Okay. You want to start us out with explaining essentially what diabetes is?
Diabetes is, as just a very general overview, too much sugar in your blood. And there's different ways that happens. And, I know you said don't go into the types, but that's really the only way to explain that what diabetes is the types. There's type 1 and type 2. And honestly, the only thing that they have in common is they're both called diabetes. They're wildly different things. Type 1 is an autoimmune condition where your body attacks a certain cell in your pancreas and breaks it down. So your pancreas you just don't make insulin to break down sugar. Whereas type 2 is literally your body just becomes resistant to insulin. So it just takes more of it to break down sugar.
Gotcha. So essentially, diabetes or glucose control, or how your body regulates glucose, starts with what you eat per se. If you're not type 1, what you eat, that causes your blood sugar to rise, which causes your body to produce insulin in order to shuttle that blood sugar into the muscles and the liver as glycogen. But over time, if you have too much blood sugar, it will be ineffective when the insulin comes out. So your body will make more and more insulin until the system fails. And that's type 2.
Yes.
Okay. So type 1, you said it was an autoimmune condition. When does this manifest, or how does this appear for people?
For most people, it appears by age 20. You can get it as an adult, but it's much more common for it to appear in children and teenagers. What causes it? We don't necessarily know what triggers the autoimmune. Nothing's been proven.
Could we say it's toxins? Toxin overload? Is that a good theory?
It definitely could be, because something triggered, in my personal belief, is a lot of autoimmune diseases are literally just toxin overload. So it's a valid theory. They actually did a study, TACT2, TACT, the number 2, or tact2trial.org. That was the chelation study. And they found that, as they chelated people, their need for insulin dropped. This was in type 2 diabetics, but I guess the logic still applies that, toxins are triggering some of that overload.
Yeah, I've seen that in my personal journey. When I started with you, I was pre-diabetic, and we'll get into that. And now my glucose control is absolutely perfect.
Yeah.
So we have type 1, which is an autoimmune condition that usually manifests early in life, where the body's immune system essentially attacks the pancreas, limiting how it controls and regulates insulin. Is that a good summary of that?
Yep.
And then type 2 is basically a lifestyle malfunction where too much blood sugar is too elevated for too long, causing the body to become insensitive to insulin, thus creating the issue of diabetes type 2.
Yes.
Okay. So what are the symptoms of diabetes?
The very general symptom is someone who is peeing nonstop and eating like crazy, but can't gain a single pound.
Okay, so was that type 1 and type 2?
Yeah. They have a similar initial presentation because what happens is, regardless of what's causing it, the blood sugar gets really high. So what happens is the body makes you really, really thirsty because it's trying to dilute that sugar. And because you're really thirsty, you're going to be peeing all the time.
Okay. Yeah, that makes sense. And then what about the weight loss? Because I've seen a lot of people struggling with weight gain when they have insulin insensitivity.
Insulin insensitivity, sure. And I think part of that is people are overweight to start with, and that's one of the triggers for diabetes is being overweight. You don't necessarily have to be overweight to get diabetes, but it's a good trigger for it. The problem with weight gain is your body can't effectively break down the glucose to utilize it for your body and store it.
Okay. So this is well and good, but I guess a lot of our listeners don't have diabetes. So how is this, applicable to most people? Because I believe there's a stage before diabetes that we call pre-diabetes. What does that look like? And maybe we can start going into testing a bit.
Yeah, so pre-diabetes. So the problem with the modern American diet is a lot of the foods we eat are really high in what's called the glycemic index. So glycemicindex.com is one of my favorite websites. You can type in pretty much any food you want, and they will tell you what is its level of glycemic index. And what that level means is how close is it to pure sugar in your body. And so, all these things that the modern diet involves bread and rice and complex carbs, your body doesn't utilize properly. It ends up getting broken down into sugar. And the more sugar you eat, the more your pancreas has to work to break it down. So you go through insulin spikes throughout the day. And the longer your insulin stays spiked, the harder your pancreas has to work. Pancreas is also kind of like a sponge. Every time you eat sugar, it has to squeeze to produce the insulin to break down your food. And it can run dry. And that's where type 2 diabetes comes in. So the way that traditional medicine will test for diabetes is one of two things. They will do either what's called a hemoglobin A1C, and this is a marker on your red blood cells, and it is actually an average over the last 3 months. So it doesn't matter what you ate today. What you ate today cannot throw off your test. Let's get that very clear. But it's averaging that marker over the last 3 months. And if you're over a certain percent, you have diabetes, that percent being 6.5, or pre-diabetes is over 5.7%. And then it goes all the way up to 15.
Yeah, so that's a very important distinction because I've seen a lot of people that have been diagnosed with pre-diabetes without an A1C reading and just with a fasting glucose reading. And that might not tell the full story because if they had their kid's birthday party the night before and they ate a bunch of cake or ice cream or something the night before that test and they had the test first thing in the morning, their insulin or their glucose could be high the next morning.
I mean, could it be? Yes, but honestly, if that's happening, that probably is a good marker for pre-diabetes. You should be able to, if you're really healthy and your pancreas is in really good shape, you should be able to eat a pound of ice cream and your glucose still stays low because it's not normally in that position. So whenever that need happens, it can spike really fast and break down all that sugar.
So that's like peak function.
Correct.
Peak pancreas function.
Correct.
Okay. So does pre-diabetes have a glucose, a fasted glucose measure that you would fall in?
It does. Do you know the number?
I do believe it's 100 to 125, if I remember correctly.
Yeah, it is. It's 100 to 125. I had to actually look it up. So anything over 100, and this is not necessarily even fasting, but random. If your sugar's getting over 100 more than an hour or two after you've eaten, that's a problem.
Yeah. So blood sugar management is kind of the quick read of diabetes or metabolic health, but the A1C is the 90-day snapshot.
Yep.
So hypothetically, would the A1C show a better predictor of prediabetes or diabetes or where you're headed?
Yeah, A1C is just a much better overall marker than random glucose.
Okay. So when people go get tested and they want to test their metabolic health, they want to test their how they function with their blood sugar and insulin. They really want to make sure they get a glucose test, a fasting glucose test, as well as an A1C, hemoglobin A1C.
Yep.
Okay. So and then once again, that's on a percentage basis, and the lab will show the breakdown of where you might land based on your percentage.
Yes, that's exactly it. 14 to 15% is horribly uncontrolled diabetes. You're probably about to go into what's called DKA, which is just dangerous. You'll probably end up in the ICU if you reach that point. Um, most people who have diabetes, their goal is to sit between 7 and 8%.
So that's pretty good, effective management of type 1 or type 2 diabetes.
Yeah, diabetics actually don't want to be too low because their problem is that they eat food, their sugar spikes, and then they take meds and their sugar drops. And if they're constantly dropping too low, sure, they'll have a really low A1C, which isn't all that good because it means they're going through periods of hypoglycemia, which is also
Gotcha.
dangerous.
So hypoglycemia, can you explain that real quickly for us, and then I'll explain some of my anecdotal experience with hypoglycemia.
Hypoglycemia literally just means low blood sugar. When your blood sugar drops too low, things stop working. Your body runs out of fuel to do things, so your brain starts to shut down, your organ starts to shut down.
I have had this happen to me in the past where I've been hypoglycemic pretty badly, and I literally had trouble forming words. I was like, I couldn't effectively speak. It was kind of scary, honestly.
Yep. If you are doing things that involve glucose regulation, my personal tip, most diabetics know they keep hard candy in their pockets just in case for a quick sugar spike.
Yeah, that is a good tip. So we have diabetes 1, which is an autoimmune. We have diabetes 2, which is basically lifestyle induced diabetes. We have pre-diabetes, which means you're on the way to diabetes 2.
Correct.
So we take a step back, and if someone is healthy, like you said, optimal function is, you can eat kind of crazy food, crazy sugar, high food, and your body still is able to regulate it. So that touches into a concept called metabolic flexibility. Do you want to speak on that, or do you want me to take that?
I'll let you take that, but I want to point out a couple more lab tests before we deviate away from that.
Okay.
They're what's called C-peptide, proinsulin, and insulin levels. So C-peptide is the breakdown of, so when you use insulin in the body, you start with proinsulin, it's the precursor, and then as it turns into insulin, you get an offshoot called C-peptide. And so when we look at those numbers, if you're starting to climb in those numbers, your glucose may be fine and your A1C may be fine. But so those numbers climbing can tell us that you are predisposed to diabetes years in the future. And so that gives you a giant window of time to do some lifestyle management changes so that you never end up with diabetes. Because once you have diabetes, you basically have diabetes for life. If you can avoid it before it starts, then you can avoid getting it. And your pancreas will function better throughout the rest of your life than once you hit that point in diabetes.
Gotcha. So if you want comprehensive lab testing for your metabolic health, you should go in and make sure you at least have a fasting glucose, an A1C, hemoglobin A1C, a C-peptide, a insulin, and a pro-insulin test.
Correct.
And that'll give you the largest window of depicting, if you're straying towards diabetes or pre-diabetes or just metabolic dysfunction.
Yep.
Okay. So that's a pretty good lab test stack for people to look at. Is this something that you would put on your comprehensive lab testing when patients come see you?
That's absolutely part of it. I also, whenever I check for diabetes or sugar markers, I check thyroid as well, just because they're so commonly linked.
Okay, so what does the thyroid have to do with your blood sugar?
My view is that if you're at risk of one autoimmune condition, you're at risk of others, and thyroid being one of the most common autoimmune conditions in America, I just always check them both.
So yeah, if there is issues with glucose disposal or insulin sensitivity, there might be a chance that you're developing something like Hashimoto's thyroiditis.
And the second logic to that is if you're struggling with things like weight gain, weight loss, it may not be sugar, it may be thyroid. So why not hit two birds with one stone? You're going to do blood work anyway.
That makes a lot of sense. Anything before we move on to metabolic flexibility?
That's all I've got now.
Okay, so metabolic flexibility. The way I would break it down is there's actually like one step in between truly metabolically flexible and prediabetes. So like on the scale, I would say there's type 1 diabetic, which is autoimmune, type 2, which is lifestyle induced, pre-diabetic, and then a normal functioning human. and how I would classify this is normal functioning humans, especially in the Western world, they burn primarily glucose as fuel in their daily lives. So it's a very carb-based, heavy diet, which doesn't necessarily mean they're metabolically flexible. And what I mean by metabolic flexibility is the ability to burn either fat via ketones or glucose, and able to switch back and forth between these two. And a lot of times people are kind of not pre-diabetic, but they might be headed that way because of their fuel primarily being glucose from carb consumption almost around the clock. You wake up, you eat a bowl of cereal, you eat your normal meals in the day right before you go to bed. You have some Chex Mix or something, or, a sweet right before you go to bed. You fasting for only 8 hours. You wake up and you have more cereal. That kind of that constant feed of carbohydrates or sugars going into your blood. Metabolic flexibility would allow you to skip a meal with no blood sugar crash. You can skip a meal, your body's going to switch over to burning fat or ketones, and then your body would just be able to adapt. And ketones are usually a preferred fuel for the heart and the brain. So being able to be metabolically flexible is very important for heart and brain longevity. So that's why intermittent fasting kind of took off recently, because it was able to address some of these metabolically inflexible problems that are popping up. Now, I don't necessarily recommend intermittent fasting for a lot of people. I think it depends on the situation. I found it's very, very effective with overweight males. On the flip side of that, I think it has actually done a lot of damage to women, because if you do intermittent fasting for too long as a woman, your body starts to regulate hormones in a different way. It causes a lot of cortisol and a lot of stress on the system.
Interesting.
I think it comes from like an evolutionary perspective. Like if you think about how we lived thousands of years ago, you're looking at the males were typically the hunters. And so when guys were starving, they needed to be sharp. They needed to be able to go out and hunt and kill. And the females were typically more the caretakers or the gatherers. And everything in a female's body is generally regulated for remaining fertile and reproducing the species. So they're not necessarily tuned to be sharp and active when there's a extended period of lack of food.
Interesting.
Yeah. So.
Okay. So you're telling our audience they can't have cereal and pancakes for breakfast anymore, and they can't have cake after dinner anymore. What should they do?
So cereal and pancakes. Let me start by saying there's nothing wrong with having a good breakfast once in a while. Good. You go out, you have the pancakes, you have the waffle. There's nothing wrong with that. It's the habitual consumption of these foods throughout the day, constantly, where you're always feeding yourself glucose. That's the real issue. So, I mean, when it comes to managing your glucose, there's a few strategies that really, really can move the dial pretty quickly. And the first one, I hate to say it's intermittent fasting, but it kind of is intermittent fasting. So, but it's a very light version. So stop eating a few hours before you go to bed and eat your breakfast a couple hours after you wake up. Try to get about 12 hours. That allows the system to kind of reset itself, works towards starting to build your ketone levels in your blood and start to build that metabolic flexibility. Again, if you're a woman, I wouldn't push that window more than 12, 14 hours. If you start to get to 16, 18, or 20 as a female, you start to have issues with your hormone regulation. Guys can too, but usually there's a little more wiggle room with that. So that's strategy number one to managing your glucose, is just don't eat carbs all the time. That's kind of like where we start, but there are a lot of like nuances in terms of diet and how we can approach it, and lifestyle things that can actually modify your metabolic flexibility and your insulin sensitivity. Do you want me to dive into those, or?
Before we dive down supplements, let's do this. Let's say you go to your doctor and they say, "Hey, Kyle, you are pre-diabetic. I want you to start taking medication, probably metformin." What do you think about that?
Well, if you're asking me what I would recommend for my clients as to what I would do, it's two different paths. So I'm the biohacker guy. I like to experiment There's a lot of research out there on metformin. I'm pretty confident in its safety profile. So I take metformin, extended release, kind of regardless. But I wouldn't start there with a coaching client. I wouldn't recommend my coaching client go talk to their doctor about getting metformin off the bat. The first thing I'm going to do is approach it with supplementation and lifestyle. And the very first thing is what we discussed. Have that overnight window about 12 hours. The number two is really your movement post meal. So if you can, what you want to do if you eat a carb heavy meal, either it could be in front of the meal too, but post is probably optimal. Once you eat your meal, you get up, you go for a 10, 15, 20-minute walk, and this activates the muscles in your legs, which then helps shuttle the glucose out of your bloodstream into your muscles where it should be. Very effective for clearing glucose. And it's really an enjoyable lifestyle strategy. You eat your dinner, you go for a walk with your wife or your husband or your dog or whoever it might be, by yourself. Enjoy the solace. It's a great lifestyle strategy. So that would probably be the second lifestyle strategy I would put in. And then we can get into things like meal timing. So it's very interesting. If you approach one meal, so say you have a baked potato, a steak, and some broccoli. So it's a pretty balanced meal. You've got protein, you've got fat, you've got carbs. But if you eat your broccoli and your steak before you eat your baked potato, that will actually control your glucose spike much more than if you ate the baked potato first.
No, why that?
So, yeah. So when you eat carbs and they go in your gut and it comes in first, they're quick digesting and the glucose makes their way into the bloodstream very quickly. But proteins and fats and fiber are very slow digesting things. So if you put those in your gut before the carbohydrates, it will slow down the whole absorption process, limiting that glucose spike.
Interesting.
So, I mean, that's a change that basically anyone can make at any time. You really don't have to change what you're eating per se, just change the order in which you're eating it.
That makes a lot of sense. And that's probably going to be one of the most helpful tips we give people off of this podcast, because they don't change a thing about their life.
Yeah. I mean, it's really that easy. Just eat your fat, protein, and fiber first, then eat your carbs. So, I mean, and along with that goes the actual structure of the meal. Like, you don't want to have a meal that's just purely carbs. Unless you're like a Ironman athlete and you're glycogen loading and you're doing insane amounts of exercise, and that's a different topic altogether. But for most people, you don't want to have meals that are consisting of only carbohydrates. You almost always want to have some kind of protein, fat, and fiber along with your carbohydrate intake.
That makes sense.
So that would be kind of the third, fourth step. Going from there, we can get into further strategies like supplementation. So there are quite a few supplements that can help manage or dispose of glucose, and these are. It's kind of a little bit tricky how you use them. So I would recommend working with a health coach or someone who knows how to use these supplements and how to advise you on them. This is also a good time for me to say I'm not a doctor and Dr. K is a doctor, but we are not giving medical advice in any way, shape, or form. Please talk to your practitioner or your health coach for implementing any of the strategies that we recommend here today. So in terms of supplements, really there's a few that can really move the needle, and the ones that come to mind are berberine, Ceylon cinnamon, and apple cider vinegar.
What was that second one?
Ceylon cinnamon?
Okay, I was just making sure it's clear because you kind of mumbled it.
Yeah, Ceylon cinnamon. So it's a specific type of cinnamon that helps dispose of glucose in your bloodstream after a meal.
I was going to ask, because it's not as simple as just you take a berberine in the morning and then you're good for the day.
Yeah. So the strategy here is usually to take it with your meal. And this is pretty important because what you don't want to do is take it after your meal, especially a few minutes after, 15, 20 minutes after, because what will happen is when you eat your meal, your glucose will spike up. And as it's falling, if you take your berberine or your Ceylon cinnamon, then it will drive your glucose even further down, causing possible hypoglycemia. So you want to take it right before or as you're enjoying your first bite of your meal. And dosages of that vary widely on how you want to do it.
Yeah, do you want to give an overview on how to dose these things?
Yeah, I don't really want to get into specific dosing recommendations too much because it's so personal.
Okay.
What I recommend here is testing. So the gold standard here is a continuous glucose monitor. So this is a little thing you put on the back of your arm, and you just click it on, and it measures your glucose all day. And so you can see what I would recommend people do is put it on. You can see how your body reacts to certain foods, how high your glucose spikes. I would implement the lifestyle strategies we talked about before. And then if you need further glucose support, I would play around with dosing berberine, apple cider vinegar, and Ceylon cinnamon. I would probably start with a shot of apple cider vinegar before the meal because the effect is much weaker than the other two. If that is not regulating your glucose effectively, I would try cinnamon. And if that's not working, I would then try berberine because berberine is the most powerful of those compounds. Dosages vary widely, so I don't really want to get into that too much. I just want to make sure that people are working with a testing method or someone who knows what they're doing to help them regulate this, because I don't recommend people just start wolfing down handfuls of berberine.
Okay. So you mentioned CGMs, continuous glucose monitors. There's a bunch of different brands out there. I'm guessing they're not all made equally.
There's actually very few brands of CGMs. So there's like 2 or 3 manufacturers of the actual product. There are a ton of providers that offer these CGMs as a service. I use Levels as one. There's a bunch of them. There's one that I really like. I'll have to get the name. We'll put it in the show notes. I'm forgetting it off the top of my head, but it's actually a CGM, and the CGM readings are accompanied with food logs. You log what you ate, and then a nutritionist, a dietitian, is on the other side giving you advice weekly on how you should tailor your diet to maximize the metabolic flexibility.
Interesting.
So that's a pretty good option. Now, CGMs are rather expensive, so they cost about $200 to run for 2 weeks, or $160 is probably as low as I've ever seen them. Sometimes $250 on the upper side. The other thing you can do is just go get a glucose measuring machine from like CVS, Walgreens, Walmart, wherever. It's a pinprick, little blood spot test. The key there is just you're going to have to do it a lot of times per day. You're going to do it before meal. You're going to have to do it, 30 minutes after your meal, an hour after your meal, and really just start to understand how you do it. Because those data points, you really want it spread out. You don't want to just wake up and test it. That's not going to tell you too much, as opposed to seeing how you actually react to certain foods. So those are the main testing strategies for like your active glucose levels. Did I cover that pretty comprehensively?
Yeah, I think that's pretty good. Okay, so let's circle back to something that we touched on previously but didn't get into, which is type 3 diabetes.
Type 3 diabetes? What is that? I thought there were 2. We only talked about 2.
Well, so now there's a new one that they're in the process. I don't think it's been officially named, but they're in the process of working this out. So you want to get into that?
Yeah, so type 3 diabetes is as of now, the colloquial term for Alzheimer's, because there is such a strong correlation. I'm not sure if they've proved causation yet, but it's so strong that it's showing that if you have metabolic dysfunction and insulin insensitivity, it leads to a degradation of your brain health, which in turn could lead to Alzheimer's. So they're saying that is the type 3 diabetes.
So, but hold on, I thought that they're saying that having low cholesterol after taking statins was causing Alzheimer's.
They've also said beta amyloid plaques are causing Alzheimer's, and that was just proved wrong by a scam recently on a research paper. So I would answer, we don't really know. Still, we're not 100% sure, but I would say that glucose is a main driver of what could cause it, along with toxins and other things that just hurt brain health in general. Is that your read of what's going on?
That's pretty much it. I think the real thing is that there's a bunch of different things that cause Alzheimer's, with the thing in common being anything that promotes degradation of brain matter. So sure, things like concussions and traumatic brain injuries, they'll break down your brain matter. Having low or high blood sugar will probably eat your brain matter. Not having enough cholesterol so your brain can't repair itself will lead to Alzheimer's. So these are all things that lead to Alzheimer's.
Yeah. So, but now they're pushing to call Alzheimer's type 3 diabetes because of the such strong correlation between if you have diabetes, chances are your brain is going to be degraded over time, get worse and worse, that could possibly lead to Alzheimer's.
And so what I don't know, and this is what I wonder, I don't know the incidence of Alzheimer's in other countries that aren't America, but in America, it's becoming more and more prevalent, I think, because of our diets and medications.
Yeah, I would totally agree. Diets, medications, toxins. I believe the majority of lifestyle chronic diseases, just could be avoided. Most of them are completely avoidable with clean diet, lifestyle, and just taking care of yourself, really.
Mhm.
So I do want to, before we move on, I do want to cycle back to the diet thing, because I just remember one more strategy that I implement with some of my clients who I talk to, and that's the consumption of protein. So along with the consumption of protein at every meal, if you aim for a gram of protein per pound of body weight, it's going to make it that much more difficult for your body to get insulin insensitivity, and generally promote good muscle development, nervous system adaptations from the amino acids, et cetera, et cetera. So having a high protein diet is a good prevention technique for something like metabolic dysfunction.
Good tip.
That was my little point there. So we've talked about type 1 diabetes, type 2 diabetes, the type 3 diabetes, pre-diabetes, a normal person, and true metabolic flexibility. We've talked about diet and lifestyle strategies to prevent it and to maximize your metabolic flexibility. We've talked about some supplements. Anything else on any of those before we move to drugs, prescriptions?
I think that pretty much covers it.
Okay. So let's move on to drugs or prescriptions. So you mentioned metformin.
Yeah.
You want to give us a synopsis on metformin?
Well, let's go over drugs as a general overview first. So there's a few different ways to get your sugar down or your insulin up or some other variation then. You can basically force your body to just be able to intake less glucose from the foods you eat. So there's medications that prevent just intake of carbs and sugar. There are medications that force your body to use more glucose with everything it does. There are medications that affect hormone markers in your pancreas to make insulin more effective. There are medications that force your pancreas to make more insulin. I think that's about the 4 categories. Did I miss one?
No, I think you've got it.
Okay. Well, let's talk about I can only think of one. I believe it was called acarbose, is the one that prevents you from being able to absorb glucose. And the unfortunate side effect of that is diarrhea, because your body has to, when there's a bunch of sugar in your intestinal tract and you're not able to absorb it, your body will try to dilute it. And so it's going to flush a bunch of water into your intestinal tract.
Which could also lead to dehydration.
Yes. So that's not a very commonly used medication anymore because it has more side effects than benefits. So it's kind of fallen to the wayside.
Yeah. So I try to generally avoid anything that drastically messes with digestion, with a few caveats there. But if it's messing or blocking a specific macronutrient, I don't think it's a good long-term strategy, because there's also medications that block fat for weight loss and things like that. They lead to terrible digestive symptoms. So I would generally recommend to avoid things that block entire macronutrients.
Yep. Okay, so the next category is ones that, and correct me if I'm wrong, but metformin basically forces your muscles to use more glucose.
Yep, I believe the function is it actually opens it up and shuttles it into the muscles more effectively. I'm not sure if it affects the actual use of the glycogen in the muscles. I think that might be associated with like the use of muscles and workouts and muscle tissue and things like that. But it effectively gets it into your muscles. It pushes it there.
Correct, because there's different ways for your body to utilize glucose. There's glycolysis, there's gluconeogenesis, and a couple of others. So I believe that metformin just uptakes your glycolysis.
Yep. I do believe that's how it works. Which could be an effective strategy in conjugation. This is kind of biohacker left field-ish. It could be an effective strategy in terms of like carb cycling and making sure your athletic performance stays high, so you can have carbs the night before, along with something like metformin to make sure that your morning workout, even though you're not eating before it, you're still glycogen loaded.
Yep. So metformin does have a unfortunate side effect. It does also cause diarrhea, usually only when you first start it. I think it probably does shuttle some glucose into your intestinal tract, and so same effect as the carbos. You end up having to dilute that in your intestinal tract. So most people, you do have to taper into it, where you start a lower dose for a few weeks and then up your dose.
It's been hypothesized that it has a major effect on the microbiome of the gut too, and so that can cause other effects. For me, it was nausea.
Interesting.
When I started taking metformin, it was like I was on the lowest dose that people prescribe, extended release. It was one 500 milligram tab a day, and I was just so nauseous. But it went away, honestly. And if as I kept running it, I stepped up the dose, and I don't have any issues. And I've taken up to 2 grams a day, 1 gram AM, 1 gram PM. Now I take 1 gram PM, and I don't have any GI effects whatsoever.
Okay. And then as a side note, metformin is considered an anti-aging medication, just in the sense that if you keep your blood sugar low to normal, your body doesn't have to work as hard, and sugar just generally does cause aging and inflammation, all that stuff. So I know plenty of people that take metformin not because they have any issues at all with sugar, but just so that they can keep their inflammation levels down.
That's the camp I am in currently. So my journey is when I started with you, I was pre-diabetic. I employed a lot of the diet and lifestyle strategies along with taking metformin. And now my A1C, last time I checked, was 4.7%, which is nearly perfect.
That's probably better than mine, honestly.
It's my average glucose, the last time I checked it, which includes all day, including post meals on a CGM, was 97.
That's perfect.
Yeah. So I don't have any issues with glucose now. And if I want to go eat ice cream, I can go eat ice cream, and I don't really have to worry about the effects. But I still take metformin for like I said, a glycogen loading perspective to help it get into the muscles, and also for a longevity effect with limiting blood sugar overall.
Okay, perfect. Okay, so let's get into the buzzword medications: Ozempic, Mounjaro, Wegovy. I think there's a couple others out there now, Victoza, etc.
Yep. So for people listening, Ozempic is semaglutide. That's the generic name of it. Mounjaro is tirzepatide. And there's one more that's actually in the FDA pipeline called retatrutide. But we probably won't hit on that. We might do an episode on GLP-1 agonist overall. But in terms of glucose and metabolic health, they work a few different ways. Do you want to start this off, or you want me to take this?
This is all you.
Okay. So they work a couple ways, and there's two main functions they have in terms of how they affect your blood sugar. One is the slowing of digestion. So you've probably seen in the news stomach paralysis from these drugs. It's a possible side effect. Usually it's because people are taking mega doses for way too long. In my use of these agents, I usually keep the doses well below half of the maximum dose. Rarely do I go over half. Sometimes I do if I'm doing an intense cut, but I never approach the full dose because I don't want any risk of vastly limiting the ability of your stomach to empty out. So what it does is it slows down your digestion. It holds the food there for longer. And naturally, because of that, if the food is not being digested as quickly, it's not entering the bloodstream to be turned into glucose as fast. So it is a slow bleed, so it doesn't cause a spike. It just will cause one of these, and then it'll go back down. The second way they work is they actually stimulate your body to produce more insulin. So overall, your insulin levels will be up, and it'll be driving that glucose down kind of perpetually because of the long half-life on these medications. It is a increased level of insulin and a decreased level of glucose around the clock. Now, you'll probably pick up, if you were paying attention earlier, that if your insulin is increased for a long period of time, you become insensitive to it. And that is one of my main concerns about these medications, is that if you're on a high dose of these things and it's jacking up your insulin to a high level for a long amount of time, you're going to become insensitive to that insulin. So these things will work less and less effectively over time at managing your blood sugar, which then in turn will lead to very, very difficult glucose regulation when you go off it. Or eventually, if you stay on it for a long time, it'll just start to get worse and worse. Is that your read of these medications?
Yep, pretty much. One more thing I want to point out, there's a ton of side effects popping up about these pancreatitis and stomach pains and this and that. So these medications, they're designed to be a short-term tool to help people lose weight, that have an inability to lose weight. But the important part to taking these medications is a change in diet. I think a lot of the side effects are happening because people are not changing their diets. They're still eating McDonald's and candy and sugar. They might be eating less of it, but that's all they're eating. Whereas you need to really be on a super high protein, 1 gram per pound body weight. You need to pretty much avoid carbs while you're on this medication. Don't give your pancreas anything that it needs to work to break down.
Yeah, I 100% agree with that. That I think is the only logical way for anyone to use these medications. To use them as a quick hack to lose weight without changing your diet is really shooting yourself in the foot, because when you go off them, you're going to gain the weight back and then some, because the weight you lose is often half fat, half muscle, further reducing your metabolic rate. So it's even harder to get out of the hole when you gain it back the second time.
Yep.
When the overall strategy for these things, Dr. K mentioned it, but really it's high protein intake. You need to get in the gym. You need to lift weights to maintain your muscle mass when you're losing weight. You know, make sure your diet's pretty clean overall, and then don't go to the maximum dose. If you can avoid it, try to only step it up to half at max and then cycle it back down, and 3 or 4 months maximum.
Oh, and he points out a good point. Cycle it back down. Don't just stop at cold turkey.
Yeah. If you stop at cold turkey, what happens is all of a sudden your insulin is not being stimulated, which drops your insulin, which skyrockets your glucose, and you'll have a very difficult time digging out of that, because you'll be starving all the time. And then you'll be super high glucose and super low, and it's just a roller coaster. So it's a cycle up, it's a maintain, and then it's a cycle down. That's the appropriate way to do it. And even the manufacturers, you know, they say, you know, you don't just stop this medication. You have to cycle off. And that's very smart, and people need to know that. That's the basic strategy on these. In terms of recommendations for these, again, talk to your doctor. Make sure you go at it with a good plan. Like if my clients who I'm working with want to go to their doctor and ask for these medications, I highly advise them to not until they have strung together at least 2 months of being in the gym consistently weightlifting and 2 months of the protein goal intake. Then I say, okay, I now think it's time. If you wanted to use these agents, you can go talk to your doctor and ask for them.
You have to be mentally ready to do this. If you're not mentally ready, nothing's going to happen. You're going to be frustrated. You may end up gaining more weight because you're going to be forcing yourself to eat, because your body's going to be confused about why you're not eating. It's just going to lead to a bad road.
Yeah. So I always advise my clients, before you go on these things, you know, have your lifestyle and diet changed beforehand, so you don't have to worry about doing it while you're on the medication. You can maximize the effectiveness of the medication. Medications are just tools. But like all tools, you know, I wouldn't try to cut a board with a hammer. So you want to use it correctly. You want to use it in the best way that we know how to. And it's pretty clear that we know how to do these now. And that's the strategy I laid out a few minutes ago.
Yeah. Okay.
I don't think we've talked about insulin yet, actually taking insulin.
Do you want to get into that?
I mean, you can give us a brief synopsis if you want to. I mean, that's basically the management technique of people who have diabetes.
I mean, yeah, insulin, you know, if we're probably not the experts on insulin at this point, modern medicine has got down really well. Endocrinologists have a firm handle on it. Insulin only applies to 2 types of people. One is type 1 diabetics who just don't make their own. There's no other medications that they can take. And, you know, the other part is anyone with an A1C of over 10%, you need insulin. Your body just can't keep up with producing enough on its own. You can get off insulin if you're a type 2 diabetic, through diet, lifestyle, all that. Your goal with insulin is pretty much take as little as possible and maintain a very tight glycemic control. Insulin, as a rule, it is toxic to the body when it's given externally. So unfortunately, every time a diabetic has to give themselves insulin, it does hurt their nerves, it hurts their body. So these tips and advice, they apply to diabetics that are on insulin as well.
Yeah, I like that. In the bodybuilder world, and this is kind of the off-label type use of things that are kind of sketchy, but the biohackers talk about this. They usually use IGF-1, insulin-like growth factor 1, which ends up spiking their glucose, and then they also use it in conjugation with insulin for maximum muscle growth. That is a terrible longevity strategy.
That's probably one of the worst things I've heard. That is worse than testosterone.
Yeah. Oh, yeah. It's a terrible strategy. But, when you're a bodybuilder, you only care about one thing. How many pounds of muscle is on my body? Not, am I going to live to 80?
Fair enough.
So we've covered the whole spectrum of diabetes. We've covered diet and lifestyle strategies. We've covered supplements. We've covered drugs. We've covered the buzzword drugs. Any last thoughts, Dr. K?
Eat your vegetables first, then eat your meats, and then eat your sugars.
There we go. Last thing I want to say is make sure, because we didn't touch on it too much, make sure you go to the gym. Lift weights 2 to 3 times a week, 1 at minimum. And if you lift weights 2 to 3 times a week, that'll build your muscle, giving more places to store glucose, giving you a less percentage likelihood of developing metabolic dysfunction. That's all we have, folks. Well, thanks for joining us. I'm Coach Kyle. You can find me on Instagram at ToxinFreeKyle.
And I'm Dr. K on Instagram as the OsteoDoc. Thank you, everybody, for joining us, and we'll see you next time.
Thanks for tuning in to another episode of the Peak Performance Podcast, your number one resource for today's top health hacks and facts. You can follow us on Instagram at the Peak Performance Pod or on X at Peak Perform Pod. You can also check out our website and weekly blogs at peakperformancepodcast.online. Again, thanks for watching, and don't forget to subscribe. We put out a new podcast every Thursday. The content of this podcast is provided for informational purposes only and is not intended for the purposes of diagnosing, treating, curing, or preventing any disease. Before using any products referenced on the podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the product. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Coach Kyle, Dr. K, and producers, disclaim responsibility for any possible adverse effects from the use of the information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referred to herein.